Hello and welcome everyone to this Support for Doctors Returning to Work in the Pandemic knowledge refresher on gynaecology, approach to the survivor of domestic and sexual violence with Ms Katherine Talbot, who is a specialist registrar in obstetrics and gynaecology here in Thames Valley. Katherine, are you ready?
Yes, thank you very much.
So for everyone joining us, we will be using menti.com today to provide some interactivity in this session, and I have popped the code for that in the chat box. Apologies for those of you who are watching this later on video, it's not so interactive. You can log in with the code 732864.
Okay, thank you very much. So my name is Katherine Talbot. I'm an ST6 in obstetrics and gynaecology, and I'm currently working as the sexual offences examiner. So today we're going to be thinking about the approach to the survivor of domestic and sexual violence. I'll be focusing a lot on sexual violence because that's my main area at the moment, but you can't really focus on sexual violence without also considering domestic violence. So first of all, these are the topics we're going to be looking at. First of all, statistics and definitions, possible barriers to disclosure, the principles of medical management following sexual violence, and onward referral pathways. But before we start, I am aware that this is a sensitive and difficult topic, and we will be discussing some content that people may find upsetting. So essentially this is just a trigger warning. That if you feel upset at any time, do please feel free to leave the webinar and either come back at a later stage or choose to watch it at another time when you feel in a safer place. There'll be some links at the end for places you can go for support. Okay, so first of all, I'd like you to go to, and I'm hoping this is going to work, to www.menti.com. Okay, so I can see that 3 people are there already. It'd be lovely to see a few more people. So I'm just going to wait for a few moments. The code is 732864. And this is obviously a rather challenging topic, so I'd like to phrase this as being a fun quiz, but I appreciate it may not be that fun. Okay, so it looks like we've got a good number of people in the quiz, and feel free to join once it's started. That's totally possible. Okay, so the first question is, what percentage of women in the UK are victims of a sexual offence at some point in their adult lives? Is it 5%, 20%, 60% or 80%? Please vote now. Okay, great. So 50% of you got the correct answer, which is 20%. So 20% of women have experienced some kind of sexual assault since the age of 16 here in the UK. Now, I noticed that some people have gone higher than 20%. And that's, I think, because we have such an increased awareness of sexual violence now. When I started doing this talk about 5 years ago, people generally estimated much less than 20%. So it's a sign of the times and perhaps the hashtag #MeToo movement that people are far more aware of the presence of survivors of sexual violence. However, this statistic is taken from the Crime Survey for England and Wales, and the strength of the survey is it includes crimes that are not reported to or recorded by the police. But one of the weaknesses is that it's a household survey. So it doesn't cover quite key populations, for example, those not living in households, so students, the homeless, people in prison, or people in hospital. So you can imagine that a large number of people in those groups would be survivors of sexual violence and therefore would not have been surveyed. In addition, although it's an anonymous survey, some survivors may still feel unable to disclose. Right, on to the next question. So what percentage of women in the last year experienced domestic violence? Okay, and I think nearly everybody's voted there, and the correct answer, 7.9%. So 7.9% of women in the last year have experienced some form of domestic violence. And I should say too that 4.2% of men have experienced domestic violence in the last year. So it's not that much lower than women. When you start thinking about domestic violence relating to a partner, then the percentage for men goes down and the percentage for women goes up. And I should refer back to say that 4% of men have experienced some type of sexual assault since the age of 16. And again, this statistic for domestic violence is taken from the crime survey in England and Wales. So, on to the next question. What percentage of boys in the UK are estimated to have experienced sexual violence? Or perhaps another way of saying it is, what percentage of men experience some type of sexual abuse during childhood? So the correct answer, and I can see the majority of people got that, is 3.5% of men have experienced some type of sexual abuse during childhood. And again, that was taken from the crime survey for England and Wales. So it was surveying people who were over 16, reflecting on their childhood experience. Now, obviously, there will be some people who do not equate the experience they had as a child to that of sexual violence and may only come to realise that much later in life. Okay. So next question. Oh, and for women, it's 11.5% of women have experienced some type of sexual violence during their childhood. So next question is, what percentage of rapes are committed by strangers? So 13%, 33%, 63%, or 93%. So I'm very glad to see that the majority of people were aware that actually the number of rapes committed by strangers is relatively small at 13%. The newspapers would have us believe otherwise, and there's often much more sensational reporting of somebody being raped down a dark alley, and that perhaps derives from some of the myths that, you know, if you walk down an alleyway, then you're more likely to get raped. And there's often a sense that if we don't walk down that alleyway, we won't get raped. And therefore that creates a distance between, you know, yourself and the person who gets raped is the person who's walked down the dark alleyway. So it's perhaps almost a myth that's created as a protective mechanism to create a them and us narrative. The reality is that the majority of people who are raped by somebody they know, a partner or an ex-partner making up the greatest figure. So actually people are less safe in their home than they are walking down that alleyway, which at the time we're currently living in, COVID-19 does give quite a lot of pause for thought. Okay, next question. This is the final question. What percentage of survivors of rape, and this is particularly women, never tell anyone? So the answer is 1/3 of survivors of rape never tell anyone. And by anyone, I mean no one. So they have never told their best friend, they've never told a family member that they have been raped. Okay, next question. And that is actually the end of my Menti quiz. So we'll now be moving on back to my PowerPoint presentation. Okay, now obviously you can't answer these questions, but I just want you to think what you would put in these gaps. So when we're thinking about rape and sexual violence, the difference between sexual violence and consensual sex is consent. So what is consent? Consent is defined as somebody agreeing by what and having the what and what to make that choice. Now this was defined in the Sexual Offences Act in 2003. And the blanks are: consent is defined as someone agreeing by choice and having the freedom and capacity to make that choice. Now, for us as doctors, capacity is relatively easy to understand. Freedom, perhaps, there are different senses of freedom, and some are quite obvious. So if somebody is holding a gun to my head, I don't have freedom to make a choice. Others are more subtle. For example, the husband that does not allow his wife to go to sleep until she has had sex with him. Now that perhaps doesn't appear as threatening or perhaps as coercive, but it is fundamentally a lack of freedom to make that choice. Okay, now the Sexual Offences Act, as well as defining consent, it also defined a number of other sexual offences. And one that perhaps it's really useful to know what the legal definition is that of rape. So rape is the intentional, non-consensual penetration of the what, or what with a what. So I imagine you can probably all work out the first three, which is mouth, anus, or vagina. But the word penis may surprise you, because that would indicate that only a person with a penis can commit the offence of rape. And that is indeed true in our legal system. Now, there's some interesting points here. In other countries, the definition of rape is different. So, for example, when I worked in Kenya for a year, the definition did not include the mouth. It was just the anus or the vagina. The people coming from other countries will not necessarily perhaps perceive that they have been raped if they have had an oral penetration. Equally, you may dispute the fact that you have to have a penis to be able to rape somebody, but I would just like to let people know that there's also the offence of sexual assault. You can also commit a sexual assault by penetration, for example, using an object, and that carries the same, can potentially carry the same weight of sentencing as rape. It's just perhaps that rape is something that we are more aware of from the media. So the impacts of sexual assault are huge, and perhaps easily to split into three areas, which are the physical, psychological, and social. From physical, one of the obvious areas in my work is pregnancy and the resultant complications. In terms of social, there can be isolation, loss of earnings, loss of education, and a significant one is victim blaming. Psychological, depression, PTSD. And somaticization is an interesting one, and I imagine anyone who's worked in a pelvic pain clinic is aware of the reality of somaticization. And there's also the really serious consequences of death through homicide, suicide, and mortality resulting from complications in pregnancy. And I'm sure that whatever area of medicine you work in, you can probably pick out some of the consequences of sexual violence and indeed domestic violence that could lead to a patient ending up on your ward. So we know that there's about 30% of people who never tell us at all that they have been sexually assaulted. So what might be the barriers for them telling us? Well, an obvious barrier in the healthcare setting for somebody telling us is, well, I'm going to show you the photo of, if you type in John Radcliffe and rape, this is the first result that you get. An ex-nurse at John Radcliffe Hospital in Oxford admits raping patients. So in my hospital, a nurse was convicted of raping patients in the accident and emergency department. So you can see that for some people, there are huge barriers to them disclosing to a medical personnel what has happened to them. Other barriers, perhaps they're easy to break them down into physical, psychological and social. So for example, when someone presents in A&E, there is a physical reality that it's difficult to maintain confidentiality. Those curtains are not soundproof. There may be psychological barriers. They may be embarrassed or ashamed, and the sort of sense of victim guilt can be overwhelming. So people may not reveal exactly what has happened. In addition, there may be social barriers, and one that we need to be particularly aware of at the time is that with the social distancing policy, if somebody has been to a party and has been raped, they may feel extremely reluctant to reveal that they have been raped at a social gathering, and that's something that we need to be particularly aware of at the moment. And then there's, of course, our barriers. Why don't we ask the questions? And something that comes up time and again is the lack of time, a sense of pressure and not knowing what to do, worrying about opening that can of worms. And I'm hoping this afternoon's talk will break down some of those barriers that we have within ourselves. And one of the first things we need to think about is, how can we ask the question? And what stops us asking? So one of the easiest ways to ask is to have a screening tool up your sleeve. And then what I would definitely recommend are the heart screening tools. So we have started using this in antenatal care, but it was first validated in a GP setting, and I'm sure would be equally useful in A&E. So the HARK is for humiliation, afraid, rape and kick. So you can start off by just telling somebody that in certain situations you always ask some screening questions. Now the advantage of using screening questions is it signifies some key things to the person. One is if there are screening questions, then there must be other people out there who have experienced what they've experienced, otherwise you wouldn't have any screening questions. In addition, it suggests that you think it might be important to ask them, which gives them increased sense that their problem is relevant to you. And it also suggests that you might have something to be able to offer to them, a way of working with them to find a solution to the situation they're currently in. So I would urge people to consider using screening questions if they are perhaps nervous about starting off that conversation. The other possibility is to use what I call connecting questions. So if you see somebody who perhaps has a black eye and the mechanism of injury just doesn't strike you as quite correct, you can use a connecting question. So something along the lines of, I see that you have a black eye. Sometimes black eyes can be caused secondary to violence, and that's something that we see a lot of in A&E. I wonder if that's something that has happened to you, or perhaps somebody who presents with pelvic pain. You could say often pain can be a manifestation of other problems in life. Sometimes we see women who are presenting with pain who have experienced deep trauma and hurt in the past. I wonder if this is something that has happened to you. Now, if and when someone discloses, it may be that you're the first person they've disclosed to, and that has quite legal significance if they choose to then go on and report to the police. So it's really important you can take down some key details, but not too much. In fact, less is more, because inevitably, if and when a case goes to court, any contradiction in the story will be pounced upon, by the defence. So it's important to keep it simple. And it's best to use the W questions. So what happened? When did it happen? Where did it happen? To whom and by whom? And also, fundamentally, what do you need to do your job? You are not there to make a diagnosis of rape. Rape essentially is a legal construct. You are there to see what needs to be done because somebody has revealed to you that somebody has put their penis inside their vagina. So what are the key things in terms of management? Well, it can be summed up within these 8 steps. You need to consider whether someone needs a forensic medical examination, do they need treatment of their injuries, emergency contraception. You need to think about sexually transmitted infections, psychological assessment, legal advice. Do they need to report to the police? Do they want to report to the police? And maybe signposting traditional services. Now, within GP, within A&E, on a busy ward, let alone with COVID-19 going on, this can all seem really quite overwhelming. There is one particularly good solution to your problem, and that is a sexual assault referral centre. So sexual assault referral centres were set up within the UK to provide a one-stop shop for survivors of sexual violence, both men, women and children, to be able to access all of these things under one roof. There are currently about 47 SARCs across England, and the advantage over them, over non-specialist services, is they provide an age-appropriate venue, forensically approved premises, so as well as being clean, they are forensically clean. They provide direct access or referral to independent sexual violence advisors who can assist people through the criminal justice system. They have links with multiple organisations and services, and also a survivor can self-refer or be referred by the police to them. You do not have to have reported to the police to go. And they will see men, women and children. And I apologise if I've used a lot of female pronouns so far. That's unfortunately because of my work in Obs and Gynae. We do get rather used to using she rather than he. So, in terms of sexual assault referral centres, this may seem like the solution, but when is a referral to a SARC not appropriate? Essentially, if there are life-threatening or severe injuries, fundamentally, life comes before evidence. And remember that a sexual offences examiner can come to the hospital. So you need to deal with the injury that's presenting to you and then consider the forensic. And I just want to point out regarding injuries that injuries do not always go along with a sexual assault. This is a really interesting paper by McLean, published in the Forensic Science International. And it showed that, well, what they did was they looked at people who'd been sexually assaulted and the injuries that they had. They also looked at people who'd had sex, I think around 48 hours earlier, who then came for their smear test and who were willing to be examined in the same way as you would at a forensic medical examination. And you can see here that in terms of people who had consensual sex, 5.9% of people had injuries, and in non-consensual sex, 22.8% of people had injuries. So, although genital injury is 3 times more likely in non-consensual versus consensual sexual intercourse, it still happens in consensual sex. So the absence of an injury does not equal consent, but neither does the presence of an injury equal non-consent. The other reason perhaps that you may not need to refer to a sexual assault referral centre is if a forensic medical examination is not appropriate. One of the leading reasons for a sexual assault referral centre is to provide the forensic medical examination. So if a survivor doesn't want a forensic medical examination, it may not be appropriate to refer. And what I would always suggest is, if you have somebody who has disclosed a sexual violence episode, then pick up the phone and phone your local SARC and get some advice. You can make an anonymous, you can have an anonymous discussion with the person at the SARC, or you can have a very full and frank discussion. So a forensic medical examination may not be appropriate, and one reason will be if the survivor has capacity and does not consent to go there, in the same way for any referral of medicine. And the other reason would be if the evidence is no longer present, so there is nothing essentially to look for. So if it's several months ago and the injuries have healed, or if the forensic DNA is no longer present. Now, it's important to know roughly what a forensic medical examination involves, and perhaps it's easy to think of it in 4 steps. One is that it's a top-to-toe examination, so from the head all the way down to the toe, including the genital areas. And that would include documentation of any injuries, and that would, the examiner would first of all draw them, but that could also include photo and video documentation. Then there'd be the collection of samples, including DNA samples, and then all of that evidence be written down and provided to aid a police investigation if they had reported to the police, and later assist the court. So it's useful to know or have some idea about how long DNA evidence persists. So for example, if there has been an oral rape, the evidence actually can persist for a surprisingly long time. It's 48 hours. In an anal rape, it's slightly longer, at 72 hours. And you can imagine that's because there are less enzymes, there's less mastication. So the DNA is more likely to survive for longer. Now, when it comes to the vagina, the DNA actually persists for 168 hours, so that's 7 days. All of these figures surprised me. They're significantly longer than I thought. So if you have somebody presenting in A&E, do pick up the phone and speak to your local SARC and ask them if it's worth having a forensic medical examination, because quite often you'll be surprised. Something that's important to note is that the more that somebody washes, for example, or brushes their teeth or changes their clothes, the less likely it is for the DNA to persist. So the advice would be is to not brush your teeth, not to wash, not to change your clothes, and if possible, not to pass urine or go to the toilet until the forensic medical examination has started. If somebody does report to the police and the police come to A&E, then they can do an early evidence kit, which at least allows somebody to pass urine. Now, if somebody doesn't want to go to a sexual assault referral centre, or there is no sexual assault referral centre, then it's important that you are able to manage the situation to the best of your ability in the situation you find yourself. And what I would say is that with the emergence of COVID-19, the acceptance criteria for sexual assault referral centres have changed quite dramatically. So, for example, in some centres, they are no longer accepting self-referrals, and people have to report to the police to be seen. So, if that is the situation, obviously you would not be expected to do a forensic medical examination. However, you would be expected to try and provide the remainder of the items you mentioned before. And I'm just going to speak briefly about emergency contraception and management of sexually transmitted infections. So what do you need to know about emergency contraception? Well, the first thing you need to know is that somebody can get pregnant essentially at any point in their menstrual cycle. Sperm can live for 5 days and the egg for about 1 day. So essentially there's a fertile window in the 5 days preceding ovulation. Now, humans are very interesting, and actually the point of ovulation can move between different cycles. So essentially you could ovulate in one cycle a couple of days early and another cycle a couple of days later. So it's really important that you just assume that somebody is at risk of pregnancy, and do not make the assumption that perhaps because they're on their period that they're not at risk of pregnancy. So how can we prevent an unwanted pregnancy after the event? The answer is, of course, emergency contraception. So the most effective method is the copper IUD. Now, the copper IUD works by essentially killing everything in its path. So it's toxic to the ovum, it's toxic to sperm, it inhibits fertilization, and it inhibits implantation. So it's highly effective. It can be used up to 5 days after unprotected sexual intercourse. However, it also has an additional role in that because it inhibits implantation, it can be used at any point in the cycle before the earliest point of implantation. So how can you work out whether somebody is likely to be at a point in their cycle before the earliest point of implantation? Well, we know that ovulation occurs roughly 14 days before the next period. And we know that implantation is, the earliest point of implantation is going to be 6 days after the ovulation. So if you're within 5 days of ovulation, then you can put a copper coil in. So for example, if somebody presents on day 17 of their menstrual cycle, so they have a 28-day cycle, minus 14 is 14 days, and they've presented 3 days early, so they're within the point for a copper insertion. This can be highly useful if someone has had sex more than 5 days ago, but is still within the window for being before the earliest point of implantation. It's important, though, to let the person know that is how it's going to work. Within the UK, within UK law, implantation is the point at which we regard a pregnancy as being, well, a pregnancy as having occurred, but for some people, for religious reasons, they may regard it as the point of fertilization, and therefore they may regard it as a method that is unacceptable to them. Now, although the copper coil is the most effective form of emergency contraception, it may not be appropriate for people who have experienced sexual violence. It is, after all, an invasive procedure. It would involve another speculum. It's not readily available in A&E or a ward setting out of hours. If you then refer somebody on to a sexual health service, the survivor may not attend. They will have a lot going on. There may also be insertion failure. And there's a significant impact at the moment on COVID-19 on sexual health services, so that something that we perhaps regard as routine may no longer be available at the current time. So if somebody is interested in a copper coil or is not interested, either way you should consider emergency hormonal contraception. So there's 2 types of oral emergency hormonal contraception: ulipristal acetate, which is a selective progesterone receptor modulator, and that's licensed for use within 120 hours of unprotected sexual intercourse, and levonorgestrel, which is a synthetic progestogen, and that's licensed for use within 72 hours of unprotected sexual intercourse. So how do these medications work? This is something I did not know, really, for quite a shockingly long time into my medical career. And the simple answer is that both inhibit ovulation or delay ovulation for 5 days. Now, if you remember that sperm live for 5 days, you essentially see that the sperm arrive, they swim around for 5 days, but ovulation is delayed, so the egg is only released after the sperm have died. And that is essentially how it works. However, you can see that the fundamental flaw is that if ovulation has already recurred, then these medications will not work. So it's really important they're given as soon as possible, and that the person is aware that they are not 100% effective. However, even if you calculate that somebody is at high risk of ovulating, it's really important that you still give the medication, because you can never be sure exactly where somebody is in their cycle. What I would say, though, is if somebody is very close to the time that they are likely to ovulate, then I would give ulipristal acetate, as it is effective even after the start of the luteinizing hormone surge. Now, when you've given emergency contraception, it's also important to discuss the options of long-term contraception and to advise the woman to do a urinary pregnancy test 3 weeks after the unprotected sexual intercourse. And there's a lot of extremely well-written guidance available on the Faculty of Sexual and Reproductive Health, both about long-term contraception and emergency contraception. Something that we're thinking about a lot in the sexual assault referral centres is, how is that woman going to do a pregnancy test after 3 weeks? And we are actually handing out urinary pregnancy tests for women, as we appreciate that some will not have the financial means to buy one, or will not be able to access a pharmacy in the usual route. So now moving on to HIV post-exposure prophylaxis. This is something that people are often extremely worried about. And it's important to have, to be able to reassure people that there is something they can do. So HIV post-exposure prophylaxis, or PEP, is now readily available. It needs to be given. It can be given up to 72 hours post-exposure, but the sooner the better. You need to emphasise that the individual must take it for 28 days. Currently, the recommendation is If you like, the standard is Truvada and raltegravir. And the good thing about raltegravir-based post-exposure prophylaxis is that if the baseline bloods are normal, there is no need for routine blood test monitoring. So if somebody has no other medical conditions and the baseline bloods are normal, then essentially they do not need to have any further blood tests. UK guideline for the use of HIV post-exposure prophylaxis is available on the BASH website and is extremely clear and well set out. The other tool that I find invaluable is the Liverpool HIV drug interaction checker, the link I've put at the bottom. And essentially it's a very easy tool where you type in the post-exposure prophylaxis that you're planning to use, and then any other medications the person is taking, and you can see if there are any interactions that you need to take note of. Now, not everybody needs to take post-exposure prophylaxis, so you need to do a risk assessment. And the key things to think of are, what is the nature of the assault? And the BASH PEPSI guideline has some very good recommendations as to which are the more risky types of sexual assault. You need to think about injuries, because if that mucosal barrier has been broken, then there is an increased risk. You need to think about whether a condom was used, or whether there was an ejaculation, and was the alleged assailant from a high-risk group. Now that may be something you think, well, how would a survivor know whether the alleged perpetrator was from a high-risk group? And sometimes we have to base that on circumstantial evidence, for example, the way that somebody was spoken to, or the grammar, or the accent. I would always recommend referring to the BASH PEPSI guideline and discussing with ID or Micro if you have any questions. The other things that are important to talk about are the side effects resulting from post-exposure prophylaxis, the common ones being nausea, fatigue, and gastrointestinal side effects. You need to arrange follow-up testing. We'd recommend arranging testing in 3 months after the exposure for HIV, hepatitis C, hepatitis B, and syphilis, and recommend that the individual has safe sex using a condom until they get the all clear. In general, the best way of organising this is to recommend they go to their local sexual health service. Now, at the moment with COVID-19, that can be extremely difficult to do, and as many face-to-face consultations are not happening. But I would always recommend that those services are still offering a helpline and then risk stratifying themselves. And in addition, there are many organisations now that have got online facilities where you can send off for a testing kit, and a person can do a finger prick test at home and get the results. Now, the next thing I want to talk about is hepatitis B post-exposure prophylaxis. So if somebody is being exposed potentially to hepatitis B, then they need the accelerated vaccination course. So unlike medical professionals who had pre-exposure prophylaxis, this is post-exposure prophylaxis. It's 3 doses, and they recommend at 0, 1, and 2 months. If you feel that somebody is extremely, the assailant was extremely risky for hepatitis B, you may need to consider hepatitis B immunoglobulin. Again, like HIV, you need to do a risk assessment, so the type of the exposure, the status of the alleged assailant, and the status of the survivor. Now, this is actually a highly effective method of preventing hepatitis B. WHO quotes 70 to 75%. And again, I'd recommend discussing with ID and Micro, and especially if you're recommending hepatitis B immunoglobulin, of which there is quite a shortage in the country. It's really important that that's discussed with ID and Micro so they're able to source it and review as to whether it's appropriate. Now, finally, I'll talk about bacterial STIs, and the ones that we commonly think about are chlamydia and gonorrhea. Now, there has previously been, in some facilities, a medication will be given immediately as prophylaxis against these bacterial STIs, but there's often concern about gonorrheal resistance. Now, in some places, it may be very difficult to test after 2 weeks. And the reason we test after 2 weeks is obviously there's an incubation period. So if we test immediately, then we're going to get negative results, whereas the positive will only show up roughly after 2 weeks for chlamydia and gonorrhea. So, as I said, there's sometimes some people would advocate giving treatment immediately, and that's certainly relevant for people who you feel are very, very highly likely to come back after 2 weeks. And now you could argue that in the COVID-19 we should perhaps be giving medication in A&E, as it would be difficult for people to access care in the community. But there are an increased growth of online testing kits that people can send off for and test. And I think that is certainly an appropriate way forward and reduces the risk of unnecessary resistance emerging. Now, it wouldn't be a sexual violence or a domestic violence talk without us considering safeguarding. So I'm going to give a very brief overview here because you could have an extremely long lecture on safeguarding. Fundamentally, for the under 13s is extremely straightforward. Under 13s are considered to be completely unable to consent to sex. So that is always a referral to social services and reporting to the police. You need to think very carefully about how you go about doing that though, to ensure trust is maintained with that young person. Now I'm sure you're aware that in the UK it is totally appropriate for people who are 16 and above to have sex, and that is both heterosexual and homosexual sex. However, there is an important proviso for 16 and 17-year-olds. So although we may assume that people can consent and have capacity, if the person having sex with is in a position of power or authority, then that creates a power imbalance and essentially negates the consent. So if a 16 or 17-year-old is having sex with somebody who is in a position of power or authority, then fundamentally that consent is negated and you have to consider it as rape or sexual assault. So it's really important if somebody in your care, you're aware that they're having sex, that you consider who they're having sex with and the circumstances that have brought them to you. Now the other consideration is that people can get quite concerned about and appropriately concerned about is disclosure in the public interest. So we know that people who are over 18 can essentially choose not to report to the police, and they have autonomy to make that decision. People under 18, then there's a sort of a grey area for a lot of young people as to, do they have the capacity to make that decision? And I would say in general, if a person is under 18, we have a duty of care towards them, and there needs to be it should never be a decision you take on your own as to whether you should report the incident to the police or to social services. That needs to be a team-based decision, depending on the particular attributes of that young person. In particular, under 16, so between 13 and 16, although it is illegal to have sex in this country, that does not mean that a 15-year-old and a 15-year-old having sex together, in their eyes consensually, have committed rape, although it is technically illegal because they're under 16. Generally, the CPS would consider that something that they did not need to prosecute, and it wouldn't be relevant for that to be reported onto the police. But these are extremely nuanced decisions, and it's important that you have a wider team discussion. Now, in broader terms of disclosure in the public interest, disclosure in the public interest is to protect individuals or society from risk of serious harm, and that includes serious crimes such as rape. So when do we need to consider disclosure in the public interest? For example, somebody who is 21 years old and has no interest in disclosing to the police what has happened. Well, we need to consider it if there have been the use of weapons, or if children or other vulnerable people or vulnerable adults are at risk. But the benefit of disclosure must outweigh both the patient and the public interest of keeping the information confidential. So you need to think, does me disclosing and the benefit of that outweigh the loss of trust both to my individual patient in front of me and to the public who perceive that coming to the doctor is a confidential process? These decisions are extremely complex, and I would always advise you seeking advice. So talk to your consultant, talk to your safeguarding lead, and talk to your county court guardian. And again, there are some extremely helpful and useful links on the GMC website to guide us through what can be an extremely challenging time. finally, when you're thinking about safeguarding, it's important to think about the risk both to the individual and to others. And something that I find very useful in both sexual violence and domestic violence is the Safe Lives dash risk checklist. This takes you through a whole variety of different forms of abuse, economic abuse, coercion, emotional and sexual abuse, and also considers children and pregnancy. It's essentially a risk stratification that provides you with some good key indicators as to whether your team needs to make a disclosure either to social services and or the police. And finally, when we think about where our survivor is going to go when they leave our service, there are some really excellent avenues of support out there. The ones I want to highlight are these 8 here. So the Survivors Trust is an umbrella organisation that supports men, women and children, and it has a telephone helpline that you can access, and will be running during the COVID-19 crisis. Rape Crisis England and Wales primarily focuses on women. Survivors UK primarily focuses on men. Then there's the organisation Gallup, and the primary role of Gallup is to support people in the LGBT+ community. So that's an extremely useful resource. It's London based, but it does have telephone helplines throughout the country. And many of these services, as well as having telephone helplines, also have interactive sort of web chat, email or text services. Then there's the Refuge, which I'm sure you've seen in the news at the moment, is coping with a significantly higher increased level of domestic violence due to the COVID-19 crisis, and Women's Aid, which supports people who are experiencing domestic violence. The Rights of Women is an extremely useful source for legal advice. So it has essentially covers all the topics you could think of regarding questions, legal questions, and it also has an extremely good resource called Report to Court, which takes you through what would happen from the point you report it to the police all the way through to a court appearance. And if any of you have an interest in the law, I would really highly recommend this as a very easy layperson read. And finally, there's Victim Support. Victim Support works to support any victims of crime, regardless of whether they have or haven't reported to the police. And finally, I'd say as a healthcare professional, if you have had experience with a survivor that was particularly challenging, I'd recommend talking, debriefing with members of your team. These can be extremely harrowing cases, and also using these avenues of support for yourself. Many of these services will support supporters, and they'll also support professionals who have provided support to survivors. Thank you very much for listening. I hope it was useful.
Thank you so much for that really valuable and informative talk, Katherine. I really enjoyed it, and I'm sure many of our listeners here will too. I've got a couple of questions for you, if that's all right. I'd also like to invite our, we have another expert panellist with us today, who's Annabelle Forsyth, who may be able to shed some more answers as well. So my questions are, we have one from Aisha Mirza. How should we approach a late presentation of rape or sexual assault where possibly there is no evidence, of course, but if it's a historical allegation, is there anything we should be thinking of?
So the important thing, thank you very much for the question. What I'd say is that is very much not an unusual presentation. You can see that with 31% of people never disclosing, you could imagine that many people take a long time to disclose, or maybe triggered by something, for example, like the Jimmy Savile or the Me Too movement. Now, they may not come to A&E, or they may come in significant psychological distress to A&E, and perhaps a late presentation is more likely in a clinic or a GP setting where something has triggered them to come, another symptom. So what I would say is that, yes, forensic evidence is important, and I spend a lot of time taking, detailed, drawing detailed body maps and taking specimens. But fundamentally, sexual violence is about consent. And actually, if somebody says that, yes, I had sex with her, or I had sex with him, actually my forensic evidence can be actually almost useless, because then it comes down to a key he said, she said, or he said, or she said, she said, because you're going to expect to have sperm in the vagina if they've had consensual sex. So it's actually the story and the history is actually really important. So I would say that if somebody makes a first disclosure, it's really important that you date and time what you're writing down, you state who else is in the room, who the account is from, and those W questions. So there is a very clear first account. So if they choose to later report to the police, that something somewhere is documented. And then it's about thinking, well, actually, do they need an STI check, even though it was that long ago? And what other avenues of support do they need? And something I briefly touched on was the independent sexual violence advocates. And there's also their equivalent, the independent domestic violence advocates, are people who can support survivors through the criminal justice system. So getting in touch with them and is a really important option, and you can find their services. Generally, they have been most sort of, for example, the Survivors Trust, Rape Crisis, or Survivors UK will be able to point you in the right direction, as would Women's Aid for NIDVA.
Thank you, Catherine. And we also have a question from one of my team, Kerry Chadwick. Does the pathway on management change if you're concerned regarding possible trafficking of the patient, particularly if the patient is reluctant to report?
So what I would say is that in lots of people who come who are survivors of sexual violence and domestic violence have really significant vulnerabilities, and they may have all sorts of reasons that they don't want to interact with the police. In terms of coming to a sexual assault referral centre, they can come without reporting to the police. And what I would say is that although some sexual assault referral centres at the current time are not standardly taking what we would call a self-referral, there is no hard and fast rule to that. And quite often we would work with people as to looking at what the benefits of reporting would be to them. And we'd also look at what other services were available to support them in that particular situation. So there are third-party organisations, NGOs that specifically work with trafficked women, trafficked people, to ensure they get the best support possible and get the best out of the criminal justice system.
Thank you. And one final question before I move to share some resources. Does a copper IUD disrupt forensic examination?
So I think that now it comes down to what's important to the woman. So yes, fundamentally it would do. So when you put a copper coil in, it is going to potentially destroy the forensic evidence or contaminate it or disrupt it, because you potentially are pushing something from the outside inside, which in a court could quite easily be disputed and knocked about. So what I would say is it's important as to what the woman wants. So if her key concern is an unwanted pregnancy, then, and she's less concerned about the criminal justice system, then absolutely the copper coil should take precedence. And that all depends on timeframes. If you've got very little time to get a copper coil in before the timeframe runs out, then it's, that would be my first priority. If you've got longer, you have a definite route pathway to get a copper coil in, then you may wish to, talk through with her the relative timeframes and say, actually we can do a forensic and then we can, definitely get you a copper coil easily within the time frame. So I think it comes down to what are the timeframes and what's the key priority for the woman.
Thank you very much, Catherine, and thank you overall for that really interesting and well presented information, which I think is really valuable for all of us. I'm just going to share some resources with the audience now. So we've had some really exciting announcements of new webinars for next week. Of course, today is a bank holiday, and therefore normally I'd be pointing you to the HEE events page where you can find a couple of our webinars, but today I'm going to also point you to the returner resource collection at bit.ly/covid-returners. This is a really broad Google document with lots and lots of revision resources, websites, apps, and a full list of our webinars. And because it's a bank holiday, this is the most complete resource available today, although if you're listening later, the HEE events page is generally more a formal way of finding those. But we've got 4 webinars coming up next week, which are brand new, including the much anticipated version of ALS, which is being taught next Wednesday with an opening from Professor Shiona McLeod, who's the Executive Medical Director of Health Education England, will be speaking to us with words of encouragement. So I really encourage you to visit this resources page and find the links to book onto those webinars. You can watch all of our webinars, including this one, which will be uploaded to the HE website. And please do allow us a week or so to edit the video files because they're very large. And there is a Facebook group which is not associated with Health Education England, but I am an administrator and many of my team are on it. It's a peer support group. You have to be a doctor to join it. And for that reason, I really urge you all to answer those screening questions, all 3 of them, so we can make sure it's a safe doctor-only environment. You can find lots of questions that have already been asked and answered by peers in your situation, and lots more links to resources. And finally, we've been asked by lots and lots of people how they can capture their learning from these sessions in a formal way. And the best thing to do in this case is to take a screenshot from either your email invitation or from the webinar itself, upload that to your portfolio. And this is the most important part, to formally reflect in whatever way you are encouraged to do so by your school, and talk about what you've learned from this presentation. And that's been the advice that we've had, that will make this a formal learning tool for your appraisal or ARCP. So thank you so much for joining us today. When you close your window, you will find a feedback form, and that feedback form will point to the after you've filled it in, to the link to the COVID returners document, which has all the webinars for next week. So thank you very much, and we'll see you next time.